It is just a huge honor for me today to be podcast interviewing Dr. Robert Gregg and Dr. Don Gregg, all the way from Cerritos, California, which is near Long Beach in California. Dr. Robert Gregg has been using lasers clinically since 1990, including CO2, FRP Nd YAG, FRP Ho YAG, surgical Argon, CW diodes, and ER YAG. He has lectured both nationally and internationally on the subject of clinical laser applications. In addition to authoring several peer-reviewed articles on the clinical applications of FRP Nd YAG for endodontic and periodontal use, he is an author of the Curriculum Guidelines and Standards for Dental Laser Education, versions 92 and 98. Dr. Gregg obtained his Mastership and Educator certification in the Academy of Laser Dentistry, as provided for in the Laser Curriculum Guidelines. He was appointed as a peer review member of the Dentistry Today CE Editorial Board and leader in CE, a co-developer of the FDA-cleared PerioLase MVP-7 pulse Nd YAG laser. He also developed and patented the LANAP periodontal protocol and the LANAP protocol for peri-implantitis. Dr. Robert Gregg is an adjunct professor at Rutgers School of Dental Medicine. Now, Rutgers School, is that the old New Jersey? What, is it called Rutgers anymore?
It's Rutgers now.
What did it used to be called?
It used to be called
UMDNJ. University of Dental Medicine, New Jersey.
Yeah, my roommate at Creighton, Gary Isolde, one of the greatest dentists ever. He's an artist. He could draw you. He could look at you for 1 minute, turn around, and draw you to where everybody would know it was you. That's where he went. So I still, I'm giving away my age. Dr. Don Gregg, who just spoke, has extensively lectured nationally and internationally and published on the subject of the LANAP procedure and the clinical laser applications of the PerioLase MVP-7. Most notably, Dr. Gregg recently published the SPIE article on the LAPIP protocol entitled Pulse Nd YAG Laser Treatment for Failing Dental Implants Due to Peri-implantitis. A member of Omicron Kappa Upsilon Dental Honor Society, who refused my application every time I asked for it. Dr. Don Gregg is responsible. I'm just kidding. Dr. Don Gregg is responsible for ongoing initiatives with dental curriculums where the LANAP and LAPIP protocols are being taught, including Rutgers School of Dental Medicine, University of Kentucky College of Dentistry, the University of California, San Francisco, and the United States Army and Navy. She is also an adjunct professor at Rutgers School of Dental Medicine. Dr. Gregg is a fourth-generation dentist after her father, grandfather, and great-grandfather, each of whom practiced in California's San Fernando Valley, and one of 7 dental professionals in her family so far. An honors graduate of the UCLA School of Dentistry, Dr. Gregg has maintained a thriving practice that focused on treating periodontal disease with the PerioLase MVP-7 for the LANAP protocol. My gosh, fourth generation dentist. So you think it's some recessive gene they haven't identified yet?
It must be, because I swore I wasn't going to do it, and look at me now.
Well, you know, it's funny because whenever you lecture in dental school, I always say, raise your hand if someone in your family is a dentist. And anywhere from 25% to a third, a quarter to a third raise their hands. But in economics, they taught me that when I was getting my MBA, that when you go around the world, you know, like the United States, like everybody talks about the Fortune 500, which doesn't even employ 12% of Americans. You know, the backbone of America, 80% is small business, 25 employers less to $1 million. And you go around the world, it's the family business. But I've lectured in India and stayed at a dentist's house where there are, I think, 27 dentists of the family, because they have that nuclear family, you know, they live with grandma, grandpa, the whole family was together. And I was in Brazil, I think it was 27 in India, and I think in Brazil it was 35. 35 people in the extended family. And I, by the way, I'm a big fan of the nuclear family. You know, America always thinks they do everything great, and I think they're great in medicine, military, insurance, banking, finance, music, and movies. That is where you're clearly number one around the world. But your education's 38th. But these 20 countries of about 1 billion people that kick all their kids out at 18, and then when grandma starts drooling, they put her in a nursing home. I think 4.5% of all Americans will end up dying in a nursing home. But the other 6 billion people, it's called the nuclear family. When you go to work, you know, and you're a woman working, who's babysitting your kid? Grandma, grandpa. And I mean, it's so, I like the nuclear family better. But that's not what we're talking about today. I have wanted you guys on the show for 1,000 days. And every time I send Robert, Bob, and Don an email, they reply back, who is this? And but I finally got him to come on the show. The only guy that ever got to come on the show and talk about LANAP was my periodontist buddy up the street, Alan Honigman.
Oh, good old, yes,
Yeah,
Alan.
and I think, yeah, he and his views on this show have been amazing because everybody wants. So on Dental Town, you know, when you're making a decision to buy this anesthetic or this bonding agent or whatever, it's an easier decision. But when you're going to buy a laser for 6 figures, so when people go on Dental Town, you know, we look at all the data. When they're searching and reading about LANAP or CAD CAM or something that's going to cost more than $100,000, they'll stay on the site for like 2.5 hours. They'll do a search for LANAP and they'll read for like 2.5 hours. Or they'll do a search on CAD CAM. They might come back. So we got these, a lot of the users just go to Dental Town, today's active topic, kind of like read the morning newspaper, like what's everybody talking about today? But I notice when they go search for like a bonding agent, they might stay on the website 10, 15 minutes. But man, when it's a laser, a CAD CAM, a CBCT, they're going to be on there for hours. So thank you so much for coming on the show since you invented this. So this Dentistry Uncensored, we don't talk about anything that everybody agrees on. The number one thing no one agrees on is these young kids are coming out of school. They read these ads that implants have a 98% success rate. But then there's people publishing that within 60 months, 20% of implants have peri-implantitis. At 9 years, that it's 40%. And the periodontists don't even have an agreed upon protocol to treat peri-implantitis. If you talk to 10 different periodontists, they'll just throw up their hands. And I mean, so podcasters are usually younger. 25%. I always say, send me an email, howard@dentaltown.com. Tell me who you are, where you live, what country, what do you think about the show? And 25% are still in dental school. The rest are all under 30. I only get like 1 email a week that says, dude, I'm as old as you. So I tell my guests, you're talking to a quarter of it's dental kindergarten, and the rest are 30 and under. So what do you do when grandpa comes in? He loves his implant. He can eat a cheeseburger. He can eat ribs. Everything's fine, no pain. And he's got mush around an implant.
Well, the LAPIP protocol is using the PerioLase MVP-7 around ailing and failing implants. And it really can be any stage of that, from inflammation around an implant to bleeding, separation. And the great thing about it is it's patient-friendly and it's very conservative in that it's a tissue-preserving treatment. There's no cutting away the height of the implant. There's no use of any exogenous materials. You don't need to place any sutures. It's just creating an environment to regrow bone and healthy tissue around the implant. And, you know, it follows the basic features of the LANAP protocol, which is used around ailing and failing teeth, which is to remove the diseased epithelial lining inside the pocket, killing bacteria, getting down to the bone modification, getting bleeding from the bone, and then creating a clot, kind of like blood jello almost. It's a very durable, strong clot that's created with heat. So you don't have to rely on the patient's ability to clot. In fact, you don't even have to take them off of blood thinners if they happen to be on them. But when you create this clean environment around the implant, we're seeing a lot of success growing bone back around an ailing or failing implant.
You know, I got to do a shout out to Alan Hogg because I realized that was the worst first question, because the first question should have said, what is LANAP and how on your journey, what was going on in your world, your life. I'm sure 90% of my homies listening right now, maybe they've heard of it, but you got to start from the beginning. But I want to give a big shout out to Alan Hogg because I remember, when did that first come out? When did LANAP first come out? And when do you think Alan got on board?
Well, I developed LANAP back in the early 90s, and we got our first FDA clearance for LANAP in 2004. So you can start the clock at 2004, I suppose.
Because I want to tell you, when I got out of school, when I was in school, 84 to 87, University of Missouri, Kansas City, there was one oral surgeon that was doing a bunch of implants. And all the faculty during their lectures would refer to him as the butcher, crazy. He was doing ramus frames, subperiosteals. They called him, one guy called him like the butcher from Langerhans, or I don't even know what that means. And then in those early years, a lot of the early implantologists, they'd have their first case fail, and the board would take their license away. And I know a couple of these guys that lived as jet-set, successful doctors with happy patients, and they died alcoholics and depression. And when Alan Honigman started using the LANAP, that's exactly what it was like in Phoenix from the other periodontists. They'd be on the phone, yeah, he's doing that voodoo LANAP shit and blah, 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 blah. And he just held his ground, and he kept seeing it work, and he kept doing it. And now everybody's like, yeah, Alan, he's so smart. He was the first guy that did that. He pioneered it in the Valley. And it's like, dude, you were throwing him under a bus 10 years ago. So don't tell me how smart Alan is. Why don't you say you're an idiot? And humans know what they know, but they never know what they don't know. And when people tell me they pioneered this or that in dentistry, I always say, well, show me the arrows in your back. Because if you don't have 20 arrows in your back, you didn't do shit in dentistry. I mean, whenever you try to change anything in dentistry, it's the most conservative bunch you'd ever meet in your life. My two older sisters are nuns, and they're liberal compared to dentists who see any change. You know what I mean? So, Robert, what was going on in your life? How did your journey end up inventing LANAP? And tell the dental kindergartners what LANAP is and what it stands for, and now the new LAPIP.
Well, let's start with the journey, because I think it's appropriate for the young dentist to understand. I was 5 years out of school, and I had reached what I felt was clinical competency. I remember I was cutting a crown prep on tooth number 3 at 3 o'clock in the afternoon, and I was starting to doze off. So I thought, wait a minute, I got to do something to inject some energy, some additional training into my career, my practice. I looked at interceptive orthodontics. I took the Brannemark implant course, but none of those really inspired me. And that's right about the time the first pulsed Nd:YAG came into the marketplace. And I said, now this will change the way I interact with my patients and perhaps maybe do some things I can't do otherwise.
Now, what was that one called?
That was the D-Laser 300 from American Dental Laser.
American Dental Laser. That was $50,000.
Right. Yeah, and I ponied up for that, and it had no training. So I had to figure it out along with our study club. We had to form a study club to figure out how to use the D-Laser 300. And I developed this protocol for LANAP, which stands for Laser Assisted New Attachment Procedure. And most people don't know an attachment from, I guess a gingival graft. They don't really understand what new attachment means, because we think, well, if we tighten up the pocket or the tissues in their pinker, then we've got regeneration or new attachment. And that's not the case. New attachment refers to connective tissue bonded to the cementum, which is bonded to the bone. And that then extends into the new bone. And that is a unique healing event. In fact, very few products have that as an FDA clearance, which we obtained last March of 2016. So it's a methodology for regenerating bone around teeth in a full mouth protocol. And so it's hope for hopeless teeth and hope for hopeless patients, so that they have a chance to keep their teeth a little bit longer, so that if in the eventuality they do need implants in the future, they're in a much better position with much more bone than they would have been had they had an extraction and graft and implant.
So how many people are using LANAP now?
Over 2,200 around the world. There's most of them are in the United States, but we have Guam, Virgin Islands, Italy.
And how many periodontists are in the United States? And what is it, about 5,000?
Yeah, that's the full membership.
And
we have about a third of the active periodontists as customers.
So of your 22, you said 2,200?
Yes.
So of the 2,200, what's a third of 5,000? So how many of those are periodontists then?
Well, half of our customers are periodontists.
So you got 1,100 periodontists using it.
Yes.
That is no small feat. I mean, that is. I mean, don't you think that that's a conservative bunch?
Yes, it is. And the reason that they purchased and invested is because of the human histology studies that we've done, 2 that we've done. And so we are in the most conservative group that you can be in dentistry when it comes to periodontal treatment.
Well, you and I got out of school. What year did you get out of school?
84.
Yeah, and I was 87. You were 1984. I was 1987, and Dawn was 2012. And, but
93.
It's kind of funny because I see. Do you agree or disagree with this? I of all the 9 specialties, I think periodontal changed the most because when I was in school and the first 5 or 6 out, it was all quadrant surgeries and it was all hemosections and mesial root plugs and endo. It was all periodontal surgery. Then everybody realized, well, hell, the easiest way to treat periodontal disease is with forceps and sunshine and pull that damn tooth, throw it away, and plug in titanium. And after 15 years of that, people are starting to say, wow, well, that's not really working. And now I'm seeing my periodontist friends is coming back, and it started, they said, with their friends and family, like their mom was in there, and they're like, well, I don't want you to pull her tooth and do an implant. I want you to try to save her tooth. So it looks like titanium doesn't cure periodontal disease, does it?
No, it does not.
And I think that these so what do you tell these dental kindergartens who are in school who are reading ads in all these journals that say implants have a 98% success rate? What would you say to that ad?
Well, you have to look at the research, and the research coming out of Europe shows that that implants have, like you mentioned, a 40 to 60% failure rate at 9 years. So what are you gonna put that implant in for? And they're also more likely to fail in a patient that has active periodontal disease that isn't being addressed. And that's a very common thing that we're hearing, is that doctors are seeing a patient that has periodontal disease, but they take a tooth out, put an implant in, and they expect that to do well and thrive. And in fact, they don't do well. They fail at an even higher rate, almost twice the rate as a healthy mouth.
40 to 60% failure rate. That's a wide margin of what if someone said pin it down tighter. What do you think the number would be?
Pin it down tighter?
Yeah, at 9 years. What do you think the body of the literature would say at 9 years? What percent fail? What number between 40 and 60%? You think it's closer to 60 or closer to 40?
I don't know. I'm just referring to the Scandinavian research that's come out. It depends on what you call failure, ailing or failing implants.
But it's hard to describe what's failure because the research coming out on the oral systemic link. I mean, just because the implant's solid, you do oral DNA analysis, you got all these oral DNA tests, you got all these bugs in there, and then it seems like every month you see more literature saying it's associated with all these other diseases. So it's kind of like it's got to get healthy, or it could be linked to all that other stuff. Of course, the older dentist, especially the older ones on Dental Town, keep saying, yeah, I made coffee this morning and the sun came up. I can't believe my coffee pot made the sun come up. It's a correlation, Howard. It's not cause effect. Do you think how much of this oral systemic link that's always in all the newspapers and journals going around, how much of that do you think is correlation versus cause effect?
Well, right now we don't really have cause and effect. We have correlations, like you said. But you can look at some studies, like Marjorie Jeffcoat did a study on preterm babies, and those that were successfully treated, meaning they actually reversed the gum disease, had about a 90% chance of delivering a baby at term. Whereas if it wasn't treated or it was unsuccessfully treated, it was down around 20 to 30%. So it's a big difference. So we do know that there's a correlation, a causation, if you will, in some cases.
So in premature babies, would you say it's causation then?
That's in the literature.
Yeah.
Who was that ADA executive director for a decade? Then I think he went to Aetna Dental Insurance. What was it? Was it Brenner? Do you remember him?
That doesn't ring a bell.
I listened to one of his lectures and then had lunch with him afterwards, and he was saying, in America, money's the answer. What's the question? He goes, the lowest low-hanging fruit on this oral systemic link deal is absolutely going to be preemie babies, because when you drop a 3-pound frog it's $1 million cash. And if we can get these girls in there and screen them and get their periodontal taken away, I mean, you're talking about saving upwards of $1 million. So you were saying if the woman had gum disease and wasn't treated, she had 90% chance of early delivery. Is that what you said?
No, if they're successfully treated, it's 90% chance of delivering at term.
Okay, what if it's not treated?
20 to 30%.
20 to 30% what? Deliver pre?
No, deliver at term.
Deliver at term. So 70% are preemie. And, you know, it's one thing when your baby's only 5 pounds. But, man, when that baby gets down to under a couple of pounds, that's $1 million.
Well, we had an interesting experience. There was one patient who had a stillborn baby. Stacy Wu is her name. It's on YouTube. An interview with her.
Can you find that? Stacy
Wu.
Wu, W-U?
Yeah, I think so.
Stillborn baby.
And when the baby was stillborn, family asked for an autopsy and went to, was it Creighton or Case Western?
Case Western.
Case Western. And they found that the baby, his organ systems were infiltrated with a periodontal pathogen. I forget which one it was. So there was a direct cause and effect there. It was the first time that there's been a proven link from gum disease to a stillborn. When we were able to get her to do an interview on YouTube, you would have thought the ADA and the AAP would have, rallied around and said, hey, we need to do something about this. We didn't hear a peep. Neither organization took an interest in that story.
Did you post that video on YouTube on Dentaltown?
No, not on Dentaltown.
Will you post it? By the way, I'm a big fan. You've had 1,500 posts since 2002. Thank you so much for that. I'm seriously a huge fan of your posts. But would you think that should go under pediatric dentist, oral systemic length, or periodontal disease?
Probably. Go ahead.
Probably a couple of them.
Oral systemic, to be sure.
Yes.
Well, so go under. So there's 50 categories. Oral systemic's under health. So click health, then go to oral systemic link. But anyway, on a YouTube video, when you're playing a YouTube video, you put share. It's got a link if you want to email or text it. But it's also has the button next to it's embed. And you click embed, and then it's got the code. And then when you're making a post on Dentaltown, there's a little YouTube icon. You click the YouTube icon and paste that embed code there. And then the video is right there. And in fact, there's another. But anyway. Yeah, so we're kind of in the early days of this still. I
think we're seeing more and more correlations, and I think it's just a matter of time before, like the Jeffco study that we have, and Stacy Wu, that we actually see causation.
Well, we'll post that. Will you post that video and then the study afterwards?
Yes.
And it'll be under oral systemic link. So go to health and oral systemic link and post that there. That is amazing. So then when did you come out with LAPIP? You said LANAP came out that you got FDA clearance in 2004.
Correct. Well, LAPIP was a parallel development. So while we're treating patients for LANAP, we weren't distinguishing it per se with implants. We were treating at the same time. But as this awareness and this problem became more pronounced for implants, we decided to give it a special name so it could distinguish itself as a standalone procedure for an ailing and filling implant as a single implant approach versus LANAP, which is a full mouth approach. So for an implant, you can treat just the implant that's affected. In periodontal disease, we consider that a full mouth infection, that the entire mouth is involved. So we want to kill the bugs. Just like we want to kill all the termites, we want to tent the house, not just the garage.
So explain how you think LANAP actually works at a science. I mean, a laser. You think of how do you think it actually works? What do you think is going on?
Yeah, I think there's quite a bit of mythology about LANAP. There's a lot of misinformation about LANAP. LANAP isn't about sticking a fiber in a pocket and killing some germs. That's not really the main therapeutic effect. It is a protocol or a recipe, if you will. And if you want to have the outcome of true regeneration, you have to follow a sequence of steps. And you need to first remove the diseased epithelial lining. You need to disinfect. You need to remove the calculus off the root surface. You need to stimulate the bone to release stem cells and mesenchymal cells. You want to then use a different setting at the same time you're doing that in order to get a stable fibrin clot. And when you get a fibrin clot that seals, it's like a membrane when you put in a graft of some sort. So it's like full mouth GTR, if you will. So it's a just like with GTR, you have to follow the steps. If you miss a step, you're not going to get the result. So it's not just firing a laser in the pocket. Because you could, I used to say, I still say it, that if you give me a paper clip and a source of heat, I can probably reduce some inflammation. But I'm not going to get a great result, a predictable result, a consistent result, because what's my source of my heat? Is it a match? Is it a butane torch? Is it an alcohol torch? How hot is that paperclip? And so when we see doctors trying to get a result with a diode, they have no idea what the dosimetry is. And the PerioLase is very sophisticated in that it has a joule counter, a power meter, and a known number of therapeutic light dose that we deliver to tissue in order to get the true regeneration outcome.
So the parameters are known to the clinician so that the clinician can adapt or change the parameters within healthy combinations or safe combinations to adjust to the patient who's hemorrhagic, maybe purulence, excessive tissue versus your dense fibrotic smoker patient where the tissue looks completely different and responds differently as well.
So we developed the protocols and the parameters for the PerioLase for all types of clinical presentations, from the dense fibrotic to the most purulent, puffy, advanced case types. So the MVP-7 refers to the 7 pulse durations that are fully adjustable by the clinician. With proper training, they know when to use which pulse duration and what's the indication for those pulse durations, and how do you stop a hemorrhagic pocket, and how do you deal with other types of tissue that have different biotypes or genotypes, depending on how you want to talk about the thickness of the tissue.
Does the laser, when you're using the laser light amplification, stimulation, emission of radiation, does that alter the tooth surface or the implant surface?
Well, that's a great question, because we were told back in the 90s by, some people like, well, you probably remember one of your mentors, Charlie Cobb. And,
he was my teacher.
Yes, I know. And he published a study that showed that Nd:YAG burned roots. And we never saw that in our clinical experience. So we were fortunate enough to run across Ray Yuckna from LSU, periodontist and a world-renowned researcher. And he says, if you're going to make some claims that you're getting, regeneration or whatever, you need histology to demonstrate that. And in my mind, he challenged me to do the histology. And I said, sure, let's do it. But in my mind, I wanted to prove that we weren't injuring the root surface, and we weren't killing the pulps. And anything after that was, gravy. So that's what happened. We did the human histology, and to my not real big surprise, but my satisfaction, there was no injury to the root surfaces, no burning, no charring, no pitting, no cratering. And same with the pulps. There was no damage to the pulps. But there was a big bonus, is that 6 out of 6 of the experimental teeth in a controlled study with a blinded examiner, 6 out of 6 showed cementum-mediated new attachment, and 2 of them showed bone regeneration. So he was blown away.
Who was? What was his name?
Ray Yuckna.
And that was after just 3 months.
Ray, how do you spell Yuckna?
Yukna.
And he's University of Alabama?
No, he was at LSU. He's now at Colorado at Aurora.
So then how are you and Charles Cobb?
We get along.
Did he ever change his mind on it, or?
I think one-on-one he'll tell you that it does work, but I think he's got a constituency that wants to hear otherwise. But I get along with him. He actually went to Georgetown for his anatomy, and that's where I went to school, is Georgetown.
They closed Georgetown down. Was it because you two went there? And after you two graduated, they said this has got to stop.
Yeah, I did
They did
that.
close that dental school, didn't they?
Yeah, 92.
Georgetown, Emory, Farley-Dixon, Northwestern, Loyola.
Right.
God, when we got out of school, they closed down 7. So
Right.
now when these people are starting to freak out because they're adding dental schools, like, dude, you know, when the first 10 years I was out, they closed down 7. Now they've added some. But, well, I tried to get Charlie on the show, and he goes, no, it's too controversial. I said, dude, he's got to be 60. I said, at your age, who gives a shit? It's Dentistry Uncensored. Come on the show and talk. No, it's too damn controversial. I don't want to go there.
I think
his email box will fill up again.
Well, yeah. Well, and here we are, how many years later from his first published paper like that? 20 years later. And the science is now supported that the LANAP protocol with the ND actually does work, and work profoundly to get true regeneration of the cementum, the periodontal ligament, and the bone. And he's having a hard time reconciling what he said over the years with what the science is now showing, that it works.
It's called an inconvenient fact. There's nothing nothing pisses me off more than a fact that destroys the bubble you live in. So right. in a practice, so you're a periodontist and you buy a LANAP. What % reduction in your quadrant surgeries would you see of flap surgery? I mean, is this something that's more niche and boutique that you'd use on 10% of the cases, half the cases? How does this change a periodontist practice? What %?
Oh, they pretty much abandon conventional blade surgery.
So they just stop blade surgery.
Yeah, for the most part. They'll still they can't resist the urge to cut something, so they might lay a flap on the retromolar pad or something like that. But now that what we were hearing is practices that were all GBR or GTR based have completely stopped doing that, except in those small percentages.
You said GBR or GTR?
Yes.
Come on, guys! In dental kindergarten, they might not know what that means.
Yeah, guided tissue regeneration. Yeah, where you put a bone graft in and use Emdogain and condition the root surface with some sort of acid EDTA or something, and then you put a membrane over, suture it, and you get some bone regeneration. And that works, but it's a
You said GTR and GBR.
Yeah, they're the same. One and the same. Guided bone regeneration or guided tissue regeneration. And
you're seeing and if periodontist gets a LANAP, those two procedures kind of disappear?
Yes, as well as conventional osseous surgery. They're just not a need to do that anymore.
Well, Howard, there's no harm in doing LANAP. See, there's no reduction of the height of tissue. There's no increasing the length of the tooth, long sensitive teeth. You are doing a very conservative approach. So after it's all done and the patient is healed and doing great, if you find a localized area that you want to go back in and do a retreat, you can retreat it with LANAP. You could retreat it with a conventional surgical technique. A lot of the periodontists are combining LANAP and doing distal wedges conventionally as a surgical technique that remains conventional. So you start out with LANAP and you don't lose any ground, and you might gain everything that you need.
Yeah, number one is patients accept LANAP far more often on a scale of about 3 to 1 compared to conventional osseous. So it's a patient preferred procedure since we're not cutting and sewing and not reducing the height of the tissue and exposing root surfaces. Which
is a huge benefit for the periodontist, because typically they're a referral-based office where they're relying on their GPs to refer patients. But the LANAP practices, those docs with the PerioLase MVP-7, they are getting patients that are being generated within their practice. Those patients they're doing LANAP on and are going out and telling their friends and family.
So it reminds me of William Shakespeare when he used to describe elderly people as long in the tooth. Do you remember that?
Oh yeah.
Yeah. And
And
now the college university plagiarism software, you know what they do? They get it digitally, and then they run it for a scan to see if what
right.
percent you play. Have you heard about that?
Yes.
Well, did you about Shakespeare?
Sorry.
But did you hear about it with William Shakespeare? They ran all his Shakespeare's through that stuff, and they found another man long before him that he borrowed heavily from.
Oh wow, I didn't hear that part.
Yeah, because I remember when I was at Creighton, one of the things my instructor said to me that the thing that's that the more you study Shakespeare, he said, you almost would think it was like a group of people because it was too much volume of work. No one could see how one guy could do all that. And now it looks like they might have found the answer to that. So what about post-operative pain? Because when you talk to the marketing people and they survey Americans, this is from many people and a study from UCLA that New Patients Inc. did, Mark Dilitush and Howie Horrocks. But basically, it's for 30 years, it's very consistent that half of Americans are afraid of the dentist, the pain, the fear, all that, the shots, and the other half are afraid of the cost. And that really you can break down America into two markets. I'm either afraid you're going to hurt me or I'm afraid of the bill. What's the pain like afterwards of 4 quadrants of osseous blade surgery versus LANAP?
Oh, night and day. There's a lot of pain and morbidity associated with conventional blade surgery. With LANAP, almost nothing. We don't prescribe any opioids. And Motrin is about all that we have to give. It's a very patient-friendly.
That's no fun. The only reason they want surgery is for the opiums.
Yeah, there you go.
Hey, how come you're not? The president of the American Association of Periodontists uses LANAP, Dr. Stephen Daniel. I mean, if you only got 1,100 of the 5,000 periodontists, and they're all doing quadrant surgeries, and you know, I've seen this for 30 years. And I can't tell you how many patients have come back to me, like the periodontists do the right side. And they say, dude, you'd have to stick a gun to my head to go back and do the left side. That's why I always tell doctors, I said, you got to do full mouth surgery because, dentists, they start off at a dental kindergarten, they do one tooth dentistry. And then after 5 or 10 years, they start doing quadrant dentistry. But the most they can get is like one side of the mouth. And I'm like, dude, next door to you is an oral surgeon. He numbs up all 4 quadrants every single day. I mean, how would you like to get a bypass? And you say, well, Howard, you're pretty fat, you eat a lot of bacon, you need a quadruple bypass, so we're going to schedule you for 1 valve a month for 4 months. I mean, wouldn't you want to just go in there, fillet you open one time, do it? Because I always thought for 30 years that those periodontists, I mean, they should know better than to flap the right side and then think they're going to come back left side. Because I give you 100 names today of a bunch of people in the last 30 years that never went back for the other side. Same thing with wisdom teeth. They'll come in for a wisdom. I say, I'm not pulling one because you'll never come back for the other 3. It's all or none. That's your choice. What do you want to do? So if the president, Stephen Daniel, which, by the way, you got to get him to come on the show. I mean, God, how much better marketing would that be to follow you with him? Because if the other 4,000 periodontists aren't using it and they have to do procedures with Vicodin and Percocet and all that stuff, I mean, that's huge. I mean, how excited were you when the president... when Stephen got his LANAP, how excited were you?
Well, he wasn't president when he bought. He bought back in the day when he was a brand new trustee, and he's worked his way up to be president. But at this moment in time, 3 of the 4 executive committee members, trustees, are LANAP trained, and half of the trustees are LANAP trained. And so we've got quite a lot of penetration, but also we've had a number of past presidents that are LANAP trained. And it's interesting that some like to talk about it and some don't. And I've often wondered why they don't like to talk about it more, because one-on-one, they'll tell you that the results are great, it's fantastic. Well, hey, would you like to do a testimonial? Nah, that's okay. So they're under a bit of peer pressure from the organization to, not talk too much about it, if you will.
Why do you think that is? Why would you think that is?
Well, what do you think about organized dentistry? Do you think that they cater to the top 10% or the doctors in the middle? They pretty much deal with the core membership are not necessarily, high-end driven. So a lot of the constituents within organized dentistry, they're not going to be able to or want to invest in the time and training. So that's one of my thoughts.
Well, my team was very excited that I finally got you guys to come on the show. And by the way, I mean, really, this is a big deal for us. But gosh darn, everybody, everybody's been emailing me. Howard Goldstein, the head of CE, says Honnigan made us a course on LANAP, but he wants you to make it. He said that he wants the man himself who invented it to make an online CE course. By the way, our online CE course, we're at 407 courses. They're coming up on 1 million views because old guys like us, we go to a convention. And the millennials, they have an iPhone and they have Apple TV, and they come home and throw the online C up on their big screen, and then they don't have to take notes because all they got to do is go back and play it or whatever. And then my editor, Tom Giacobbe, who, by the way, shout out to Tom Giacobbe. Today is his 18-year anniversary of the editor of Dental Town magazine. A lot of people always send me stuff and they say, hey, will you print this in Dental Town? It's like, dude, the only reason he stayed there 18 years because he's a dictator. He's never asked me my thoughts on an article one time. I mean, my management style is find the smartest people you can find and get the hell out of their way. And these dentists that don't delegate, they don't realize that you're going to die someday. So if you don't delegate till the day you die, the minute you die, everything you created just falls apart. I mean, when you die, you're going to delegate 100%. So start delegating it now to see how your team is doing. And then Tom Giacobbe and the editor is Sam Middlestad. They both want an article from you guys too. So if you build us an online CE course and do an article with Dental Town, I think it'd be huge. And you ought to get that guy. Stephen Daniel to talk about that because we're not and then the other thing that I'm in several dental schools a year. The students tell me that when they're studying periodontal disease, that when you're in academic school, they say that their colleague leaders like Stephen Daniel and the American Association of Periodontists, that they don't believe that there's an agreed upon protocol for treating peri-implantitis. But there is for a pulpotomy and a chrome steel crown at a pediatric dentist. There is for wisdom teeth. There is for root canals. And they asked, why is that the only one of the 9 specialties that doesn't even have an agreed protocol on their number one disease? How would you answer that?
Well,
because nothing's worked reliably, and everything's been tried, from the most conservative to the more aggressive, surgical, grafting, you name it, kitchen sink, try everything approach. No matter what's been tried, it's not successful. It's a hit and miss, 50-50 chance that it'll work. And that's not what we're seeing with LAPIP. It's much more successful than that. And that's a challenge. We have
an oral surgeon in Texas, Gary Schwartz, who's documented his peri-implantitis cases treated with LAPIP, and he has a 90% success rate. And he defines success as Gary Schwartz, McClellan, Texas.
Schwartz?
Sounds right.
Yes.
Gary Schwartz, oral surgeon where?
McClellan, Texas.
McClellan?
Yeah, South Texas, near the border.
I'm 100% Irish. He sounds like he's a drunk Irish guy. Are you sure? You sure he's legit?
No, he's a fun guy. He's
you would enjoy him.
He's got a ranch and he raises trophy deer and trophy bass. So he's got quite the outdoorsman.
Wow, that is and what's he saying from oral surgery that on his peri-implantitis he's got what percent success rate?
90%.
Wow. So okay, so then the next question is, and I hear this all the time. They're coming out of school. We were in AT Still 2 Sundays ago, and there's kids. It's private school. I mean, there's kids walking down there, $400,000 in student loans, and a lot of them are starting to get smart because of social media in Dental Town. They don't realize. A lot of people think, well, you know what? I'm just going to get a job at corporate. and pay out my student loans, and I'm just going to do that and be Mr. Mom or whatever. What they don't realize is that if that was a great idea, why does the average dental student only work in those places 1 to 2 years? I mean, the turnover rate as an associate, and don't throw Heartland and Pacific and Aspen under a bus, because it's the exact same. 80% of the associate jobs are in private practice, and nobody keeps their millennials. I mean, and it's not even just dentistry. If you look at the FANG stocks, Facebook, Apple, Amazon, Netflix, Google, Microsoft, they have the same thing. Their average millennial only stays 1 to 2 years. They stay the shortest at Apple, 1 year. So when everybody's saying how great Jeff Bezos is, shit, he can't even keep his average employee a year. And the one that keeps them longest is Facebook, which is 2 years. And in corporate, the longest guy keeping associates is actually Rick Workman of Heartland Dental. And every kid that stays there 2 years longer, I ask him the question, why do you stay so long? And he says, because the continuing education is amazing. If I stay here 5 years, I'll get my fellowship, my diplomat, I'm getting all this training. They're looking for mentors. And as soon as they get a job and they find out they're in a Medicaid mill and they're not learning anything, they're gone. And it's the same thing when they go work in Silicon Valley. You know, once they've started working on a project, it's really fun, exciting, and growing for a year or two. And then they find out that they're just going to keep doing that same shit for the next 10, 20, 30 years. And they're like, screw that, I just got an offer from Uber. I'm going to go work on driverless cars. And then they go work at Uber on driverless cars. And once they figure all that shit out, then they're like, well, hell, now I want to go to Apple and work on e-commerce. I mean, they want to keep intellectually growing. They're looking for mentorship and all that stuff. But they say to me, Howard, yeah, I worked for this place 2 years. I worked for this associate. Screw it, I want to set up my own practice. But I graduated $350,000 student loans. I just bought a practice for $650,000. I'm 29 years old. I'm under $1 million. Do I really have to get $100,000 CBCT, $100,000 LANAP, and $100,000 CAD CAM? And that could be, all those three could have been $150,000. So if they go buy a CAD CAM, a Cerax Serona, you know, say $1.25, $1.30. What's the LANAP costing these days with the training and everything, the whole package?
Well, I'm glad you brought that up, because there's a lot of misunderstanding about our pricing options. We have 5 different pricing options, from $70,000 to $125,000, and anywhere from $1,500 a month on a lease to $2,000 a month on a lease.
Yeah, I want you to repeat that. $70,000 to one what?
125, not 135, 125.
Okay, and then the leasing option was what to what?
1,500 to 2,000, depending on what your value proposition is or your price point is.
And it also, and how long is that lease? 60 months or 70?
Yes, that's
60 months.
Yeah. 60 months, but there are several different options. Basically, it can be customized to whatever you want or need to do.
So if you got an implant today and bought LANAP, when it was finally paid off, then you could use it for the peri-implantitis on yourself.
Well, you know, we also have a financing program that's 6 months at $695. So it really allows the doctor to ease in. And what they'll find with LANAP and LAPIP is that it's pure profit with one patient a month. You don't have to build up a reservoir of patients and then all of a sudden now it's starting to pay off. Because the lease payment, you're doing full mouth, one visit, half another side, another visit within a week, and you're talking about $4,000 to $6,000 in revenue for a $2,000 a month lease payment. So they did learning business. So basically, when a millennial looks at a number, like they'll say, okay, it costs $70,000 to $125,000, that you're thinking of as a balance sheet number. A balance sheet is your asset, say LANAP, equals your liability, what you own it, minus the equity you have into it. But that's not how you look at things. It's the same thing as real estate. Like, I'll buy your house for $1 billion. I'll buy any house in America for $1 billion if the terms are $1 a month for 1 billion months. Because I'll rent your damn house out for $1,000 a month, and they're always looking at the price of a house. They're always saying, well, this house is. You hear people talk. Well, this house is $275. I really want the one that's $320, but I think I'm going to go for the one. Dude, what is the interest rate and the terms?
I mean,
Right.
so those are statement of cash flow numbers. A profit and loss, a P&L, a statement of income, that's for third-party tax collectors, the IRS, if you're publicly traded, the SEC. It's got artificial numbers, depreciation, deferred taxes. The only thing you want to master is your statement of cash flow, and every damn dentist I know has a CPA that only gives them profit and loss. The only thing your CPA does is gives you a stupid number for your taxes. And the
Agreed.
balance sheet, the only reason you need a balance sheet is when you're going in for your divorce. And
Agreed.
and so you need a statement of cash flow, which nobody
Right.
gets. And that's why the biggest takeaway I can give you is that every single dentist that changes their CPA to somebody who only CPA firms that only do dentists, like the American Academy of Dental CPAs. Tim Lott is the guru in there. And once you switch to a CPA, then they can show you how this technology affects your statement of cash flow. Like a lot of dentists say, well, I'm going to buy a CAD cam because if I buy a CEREC machine, I won't have a lab bill, and then I'm going to get rich. And they're like, hold on, Spanky. Hold on, let's sit down. And they got data on 8,000 dentists. And they can say, of these 8,000 dentists, here's the ones that, so now you should lump supplies and lab bill combined because, yeah, your lab bill goes down, but you're buying a lot of $15 blocks. And you used to take an impression, temporize, flip the chair an hour. Now they're sitting in that chair for 2 hours or 3. But on a statement of cash flow numbers, if the payment is $1,500 to $2,000 a month, tell me exactly what that person could do in their office that month to get that $1,500 back to cover their payment, $1,500 to $2,000, and then get maybe another $1,500 to $2,000 to increase their return on asset, which is their dental office.
Well, the average general dentist has approximately 3 patients a month that they should refer or that does need periodontal treatment, such as LANAP. So if you work those numbers, 3 patients times, say, $5,000, that's $15,000. And we're talking minimum numbers here because there's a lot more disease out there than most dentists appreciate. So you're talking $15,000 to pay off a $2,000 loan payment.
Those would be the 3 patients in a GP's practice that they would send for conventional surgery to the periodontist or for LANAP. That won't go. But all of the periodontal patients in a GP's office, those that you would conventionally do scaling and root planing on, those are all candidates for the LANAP protocol. So it's those 3 you would have referred out, plus the ones that you would be keeping in, but maybe doing scaling and root planing. Do you want repair as a healing event, or do you want regeneration as a healing event? That's a question for your patient to answer.
And, you just said something very genius. For years, I had a prescription pad by every single phone called Getting to Yes. And when someone called and we said no, we tracked all of our no's. Because a lot of dentists, they'll say, well, how do I get more new patients? I'll say, well, first of all, you don't need any new patients. You lost all your patients. I mean, you go to a town of 5,000, and here's old man Henry who worked from 25 to 65. He got 25 new patients a month for 40 years, and he still needs new patients. I mean, everybody in the county's gone and left him 3 times. So, they all come and leave him for a decade and then go back because he's the low-hanging fruit. But like they'll say, do you think I show him on Saturdays? And I'll say, well, how many people ask you a month if you're open Saturday or evenings? Or they'll say, well, do you think I should take this insurance? Well, how many people a month ask you? And then it's the same thing with referrals. I mean, I ask these dentists, okay, last year, 2017, how many sets of Wizzies did you send out? No idea. How many molars did you send out? No idea. How many cases for periodontal surgery? No idea. Then I say, well, what are you studying? And they say, well, I'm studying veneers. I'm going to be a cosmetic dentist. And I said, well, how many veneers did you do last year? I never did any. Okay, so you've never done veneers, and now you're going to be a veneerologist. And I mean, if you're setting out $100,000 a year in perio, or $100,000 a year in molar, or $100,000 in perio, I'd start there, because business in 3 words is supply and demand. They don't even measure what's coming in and leaving, what's coming in the front door and referring out. And if you can't measure it, you can't manage it. But what do you think the average general dentist? Well, if you got 5,000, we could do the math. There's 5,000 periodontists. And how many patients do you think they see a week for surgical procedures, not routine hygiene?
Oh, a week? I would think in terms of days. They probably see 4 a day.
4 a day
So
on how
that's
many days a week? Do you think there are 4 or 5?
or let's say a 4-day work week.
Okay, so then you would take 16 times 5,000, and then there's only 125,000 dentists who work 32 hours a week or more. There's 30,000 specialists who work 32 hours a week or more. There's 211,000 dentists living in America who have a license to practice dentistry, but a lot of them are retired. Some of them are disabled. But so if you took 16 times 5,000, which I can't do in my head, and then you should be able to figure out the number of referring cases per dentist.
Correct. And, we've talked about the periodontists, that the LANAP protocol is suitable for them, but LANAP is suitable for the GP as well. They can realize these numbers. We train them so that they can get the results that the periodontists get. In fact, we have a joke that we have to untrain the periodontists from some of their paradigms so that they can appreciate this new technology and not to do certain things like remove the granulation tissue. GPs will do things like occlusal adjustment, which is part of the protocol, and periodontists have a hard time with that. So actually, GPs can do quite well in terms of clinical outcomes.
So go through it. So there was a wide range that this lab costs between $70,000 to $125,000. Explain the range, the training. Explain if someone says, "I want to do this," walk them through.
Well, that's another great question, because people think that the training is expensive, but this is a postgraduate type of training. So if you go to the Pankey Institute and you go through 5 evolutions or 5 continuums, you're spending about $30,000. Well, guess what? That's about how much our training is for 5 evolutions. So we're competitive with the other training organizations that are out there. But at Pankey, they don't pay for your room. We do for our students. They don't pay for your meals. We do. And we also pay and cover the transportation costs and the hotel. So we are
what about drinks and weed? Because they just legalized weed out there.
Yeah.
So do you get your choice now? It used to be beer and wine, and now it's beer, wine, and a bong.
It's all included.
By the way, I want to change one thing on your pitch, though, because I firmly believe, watching people for 30 years, if you don't do the procedure once a week, you're not going to get profitable at it. People get into sleep apnea, and then they do send-home tests like once a month. Or they'll do an implant. It's like once a month. They never reach critical mass. If you don't do something once a week, you never get profitable on it. And if there's 5,000 periodontists, they work 4 days a week, they see 4 procedures a day, they're doing 30,000 procedures, 125,000 dentists. That means the average dentist should be referring 4 cases. That'd be 4 cases. What was the unit? 5,000 periodontists, 16 a week. That'd be 4 cases a week. So, yeah, I mean, there's 125,000 dentists. So, if 5,000 periodontists seeing 4 times 4, 16 a week, that's 30,000 procedures a week. So, 125,000 dentists on average are referring 4 a week, but you need to keep all the math. They do 1 a week, because I wouldn't want to get a vasectomy by some guy who did it every other month. I wouldn't want to get
Howard, periodontal disease is one of the most common diseases in the United States, in the world. So if 85% of the population has some form of gum disease, that's what you're going to see more often in every one of your patients. So if you're looking for one thing to do that most of your patients need, it's going to be gum disease treatment. And doing LANAP for regeneration as the healing event is huge. So, you were talking about the associate who wants to branch out and start their own practice. I can relate to that, breaking out of my dad's practice. And we were growing steadily just fine. But it wasn't until I brought LANAP into the practice that we just took off. And I let people know that we were offering this LANAP protocol, and people would come out of the woodwork from far away just to get this done. In my GP office, I ended up doing so much perio, I had to hire an associate GP to do the rest of the dentistry I couldn't get to, as well as specialists as well. I mean, I hired 3 specialists and a full-time GP and kept all the perio in my hands in the select cases of the patients that I wanted to treat. And our profit went up huge. LANAP was and is the most profitable thing that I do in the practice.
And Howard Goldstein wanted me to remind you that You think you're all that in a bag of chips because the president of the AAP, Dr. Stephen Daniel, uses LANAP, but Howard Goldstein says that he uses LANAP and that he is more all that in a bag of chips. And that you should be telling everybody that the director of Dentaltown Online CE uses LANAP, and that should be all. He says, how much more influence does it get than that?
Well, regards to Howard.
Yeah.
Yeah. So, by the way, if you do want to do an online CE course, he's Hogo, Hogo, at dentaltown.com. I'm Howard at dentaltown.com. But it's actually, but go back to the training, though, because, so you don't sell a laser. It's by Millennial Technologies, right, the laser?
Well, isn't it kind of interesting that the company's name is Millennium and the target market now for so many of us is the millennials? I just kind of got a kick out of that as I think about it.
So are you Millennium too?
Yes.
So you're
Millennium Dental.
So you own Millennium?
Yes.
Oh, I didn't know that. So you own Millennium Dental Lasers. Is that what the name
Millennium Dental Technologies. Millennium Dental Technologies is the company. And that's the company that manufactures the PerioLase MVP-7. And then there is a separate and distinct corporation called the Institute for Advanced Laser Dentistry. And that corporation is responsible for the research and training. And you were asking about the training. The training is in
Colorado?
Well, we do training in Cerritos, Colorado, in New York, and it changes depending on the season where we offer the training. Every month we train in Cerritos, and then depending on the season, it's either in Colorado also or in New York also. And as the training director for the Institute, I get to oversee 50 certified ILD instructors who are trained to provide hands-on training to doctors who come through the training program. It's 5 days of training, 3 up front, Thursday, Friday, Saturday in a row. You come get trained. You treat live patients. So that's the other thing that our training does is we provide the patients for doctors to treat. They're actually doing the treatment. We're there to hold their hand. And so they get to see how the energy interacts with the tissue. And that's going to be different for different patients. So they have live patient experience for 4 out of the 5 days of training. The 4th day of training is 6 months after the first 3. And then the 5th day of training is 6 months after that. So there's repetition, and there's also introduction of new concepts and new training efficiencies, new treatment applications for the PerioLase as well.
Well, I don't smoke pot, but I'm just for the millennials. They'd have to go to Cerritos or Colorado if they want to have recreational pot. In New York, you actually need a prescription. Do you put that on the? Do you put a little asterisk on there for the millennials that they'll have to? Do you provide a doctor on site to write them prescriptions? That's what I'm asking.
Well, they don't need them here in California.
I know, but you train in Cerritos and Colorado, you don't need them. But if they take your course in New York, do they realize when they get off the plane they're going to need a prescription?
No, I don't think so. Okay. But that's why we encourage them to come to Cerritos because we're central. We're the what do they call it?
Ground zero for LANAP.
Yeah, ground zero for LANAP.
Ground zero for LANAP. So how's it going? Is your company is it growing, flat, shrinking? Is it exploding? I would think with all the I would think you got a lot of wind in your sails at this point.
Yeah, we've been growing steadily since 2001, and we're on a uphill slope. It dipped a little bit right after 2008 in the recession, and doctors could not qualify for leases and loans. I remember we lost around 21 signed customers because they couldn't get financing. So that's starting to loosen up now, and it has been for some years. So we're back on another growth curve, and I think it's important to understand why we're in this. We're in this to change the standard of care for treating gum disease and have more patients being treated because the treatment rate is around 3 to 4% of those patients that need it. And we have 200 million Americans, more actually, let's call that a round number, 200 million Americans with periodontitis. Half of them have moderate to severe, 40% don't know it, and only 3 to 4% are getting treated. So if we can cause an increase utilization rate, much to the chagrin of the insurance companies, this is what's happening. We're bumping the utilization rate up for periodontal disease treatment, and that's been the goal from the very beginning, as well as getting LANAP into the dental schools and the periodontal residency programs, which we're doing now at Rutgers and UCSF, Colorado, and also the
Army and the Navy and the Air Force shortly as well. Now, the huge boost came in 2016, I think, to move us into the university environment, the academics, when we got the FDA clearance for regeneration. We're the only dental laser and protocol that have science to prove regeneration, and that's with human histology. That's the only way you can prove it, and we're the only company who has that. And I think on the heels of that has been a huge boost in the academic environment to acquire this and to start training residents. And those programs are so competitive now because the doctors coming into those programs want to be trained on the LANAP protocol.
So what about buyer's remorse? Do you still offer a 6-month money-back guarantee?
Yes, we do, and it's a clinical guarantee on the results, meaning if you're not getting 90% of your patients and their pockets reduced by 50%, then we'll buy it back. And
say that,
it's not limited.
Repeat that.
If a student has gone out for the 6 months trial period and they're not getting 90% success in their patients and their pockets, at least 50% pocket reduction by regeneration, not by amputation, then we'll refund the money, refund the purchase price. And we've done that 2 times out of 2,200 doctors.
Yeah, most people like Alan Honigman would tell you, you'd have to pry that PerioLase out of my cold, dead hands before you can have it back.
But we also have, for the nervous, someone will say, well, 6 months isn't enough. I need a 9-month. Okay, it's going to be better results at 9 months than at 6. So, all right, if that's your sticking point, let's do that. We've had other docs say, I want 12 months. And really, by the time they hit, 6 months, they're saying, wait a minute, I already see the results.
Yeah. My 4 boys are 22, 24, 26, 28, and I have a 30-year money-back guarantee on all 4 of my boys, and they're not honoring the contract that I signed for them at birth. Final question. I can't believe we've already gone 10 minutes over. Another question that really bothers the kids when they come out of school is, there's now over 600 dental implant systems. Being on the other end of this, treating dental peri-implantitis, do you think some implants are more susceptible to peri-implantitis or not, or is that have nothing to do with it? And if they ask you, come on, you treated peri-implantitis on probably 100 different implant systems, she doesn't want to go study 100. I mean, if you went to gosh darn Cologne, Germany last year, there were 145 implant companies that had a booth at Cologne. Narrow it down for. Are you seeing more disease on some implants than others?
No, it doesn't matter.
It doesn't matter.
It doesn't matter what the implant, the protocol is the same. You follow the protocol, you get the results. And let me tell you something that a lot of dentists don't understand, and it's why I think the relatively closed pocket treatment that we do is working. There's been some studies, one Tom Wilson published and a couple others, that show that there's metal corrosion, titanium corrosion in the soft tissue. And one of the possible causations of failing implants is this corrosion is the problem. So if you're doing a flap and putting graft material, and then you put the same tissue flap with the corrosion byproducts right up against it, well, it's gonna fail. So why is it that we're effective around implants? Well, we don't make a vestibular releasing flap and push the tissue away. We keep the tissue near the tooth and we go around the tooth with our laser. And I believe that's part of the reason we're extremely successful, is we're not treating the implant the same way others are treating it. We're treating both sides of that pocket, the soft tissue and the titanium, and it's not matter what kind of implant it is. we're still getting the
I'm a big
results.
fan of lasers. I don't know if you know this, but I actually had laser hair removal, and that's why I'm bald. And it's been extremely effective now for over 30 years. I just want to end on one note. If you walk out my house one way about a block, there's an orthopedic surgeon friend of mine, and you go out the other way about 3 blocks, there's another one. And the one thing those guys do all day long, we're talking about 20% of implants have peri-implantitis at 5 years. You ask any of them when they give you a hip or a knee or anything, they say 5 years. And dentists always say, "Oh, you get an implant, you'll take it to heaven." Well, that's not going to happen. And the fastest way to satisfaction equals perception of what's going on minus what I expected. Like when I get done doing a root canal, you don't tell people, "Oh yeah, you'll be fine, go back to work." I lower their expectations. I say, "Dude, when this anesthetic wears off, I hope you have a pistol because you're going to want to suck on it. I mean, you're probably going to wish you'd never been born when that wears off." So they're at like ground zero, like, "Oh my God." Then they come back a week later and say, "Howard, you're not going to believe it. I mean, it didn't even hurt. I took like 1 pill." So every time I pull out a tooth, I hold that bloody tooth in front of them and say, "Look at the hook under that root. It was hooked back up underneath your cheekbone. I swear to God, when this anesthetic wears off, you need to find a cliff. You're probably going to want to dive off it." You lower their expectations. How long does an implant lose? You know what? I mean, I don't care if it's a knee, a hip. When you start replacing parts when the human body with titanium, you're probably going to get about 5 years. Maybe you get longer if you take care of it. If you come in here every 3 to 6 months to get your teeth clean, if you quit smoking, you join a yoga class. I mean, I've always noticed that implants last longer in yoga instructor than Irish alcoholics who live in a barn in Kansas. But lower people's expectations. And also, you'll be much happier in life if you lower all the expectations around the people around you.
Well, one of the things that we say with the PerioLase MVP-7 value proposition is we understate and overdeliver. LANAP is what pays for the laser, but there's many other procedures you can do. And I just posted the other day enamel caries removal on Dentaltown to remove the organic debris with the PerioLase and then put in a preventative resin filling.
And we're so over. We got to go. But I just want to say one thing more from the MBA training. That is why you look at the Fortune 500. No one ever is appointed a CEO that comes from sales, because salespeople do what they do because they overpromise and underdeliver. So the Fortune 500 doesn't promote anybody to CEO from sales because those people are freaking sociopaths. They're insane and they never deliver. You always want to bring someone in from accounting, finance. If you make a product, you should be the engineer. You should have worked, on your product. But yeah, marketing people overpromise, underdeliver, and the way you handle patients, staff, everyone around you, underpromise and overdeliver.
Right. Well, check out that post on enamel caries removal on Dentaltown. I'm getting some interesting responses like, "Why would you do that?"
Well, email me the link to that. I got to run. Email me the link to that post, and I'll push it out on social media today.
Okay.
Hey, it's a huge honor. I've known you guys for 30 years. How many times have we run into each other at conventions and speaking and all that?
Well, you've been to our clinicians meeting in Cancun.
Yeah.
And you and me are in a picture for my avatar on Dentaltown.
I know. You do that just because it makes you look so much more handsome.
Well, yeah. It makes me want to not have hair.
But hey, seriously, thanks so much for being a pioneer. I know dentists are a rough and ruly crowd, and you guys, you guys proved them all right in the long run. And a big shout out to Alan Honigman because man, he stood there like a soldier. 10 years ago, it was brutal. Now he's laughing all the way to the bank.
Yes, he is.
Yeah. So thank you so much for coming on the show. I hope
you
two have
it's been an honor and a privilege.